is Roxana Ardebili. I'm a first-year categorical medicine resident, and I'm going to be talking about bactericidal agents being more or less effective than bacteriostatic. When I initially chose this topic, I honestly didn't understand how complex the issue was going to be. Going back to medical school, I remember being taught that antibiotic classifications, which included mechanisms of action, and bactericidal versus bacteriostatic were presented as just another intrinsic characteristic of the antibiotic. Common bactericidal agents were those that disrupted bacterial cell walls, while bacteriostatic were those with varying other mechanisms, such as inhibiting bacterial ribosomes. Each antibiotic fell neatly into its category without a second thought. In this talk, I'll mostly discuss bacterial vancomycin and bacteriostatic linezolid. When we talk about bactericidal versus bacteriostatic, we commonly make these assumptions. Bacteriostatic agents slow or inhibit the growth of bacteria but do not kill them, and bactericidal agents actively kill the bacteria. It is assumed that bacteriostatic agents require phagocytic cells to clear bacteria and are therefore thought to be less effective without an efficient immune response. Therefore, we assume that severely ill and immunosuppressed patients with bacterial infections should be treated with bactericidal antibiotics. Some specific conditions are thought to always require bactericidal antibiotics, such as endocarditis, because the cardiac valves are considered as focal immunosuppressed regions that are poorly accessible by phagocytic cells. The origin of the bacteriostatic versus bactericidal debate appears to derive from older case series that evaluated patients with bacterial endocarditis. Starting back in the 1950s, it was found that bacteriostatic agents, including a variety of tetracyclines and macrolides, resulted in poor outcomes when used to treat endocarditis. This was likely due to achieving very low blood concentrations. For example, in this study from 1971 about streptococcal endocarditis in rabbits, it states that the central importance of phagocytes is evident in treating processes like pneumonia, where bacteriostatic antibiotics can hold the population steady while phagocytes clear infection. However, almost complete absence of phagocytes in large areas of vegetations has been noted, which is consistent with findings in human endocarditis and probably explains the failure of bacteriostatic drugs in endocarditis. So moving forward, in order to discuss bactericidal versus bacteriostatic, it is important to note that there is a more formal way to define them than just via the mechanisms of action. We first need to note the MIC, which is minimum inhibitory concentration, is defined as the concentration that inhibits visible bacterial growth at 24 hours. Also, MBC, which is minimum bactericidal concentration, is the concentration of the drug that results in 1,000-fold reduction in bacterial density at 24 hours. Therefore, the definition bactericidal means MBC to MIC ratio less than 4, and bacteriostatic means MBC to MIC ratio greater than 4. In order to make this a little more understandable, we can say that an antibiotic that achieves greater than 1,000-fold reduction in bacterial density but does so at a concentration that is 8-fold above the MIC is considered bacteriostatic, despite clearly killing the bacteria. Further, an antibiotic that achieves 500-fold reduction in bacterial density at a concentration 4-fold above the MIC is considered bacteriostatic. These are somewhat arbitrary laboratory definitions of in vitro comparisons to predict outcomes of antibiotics in vivo. When we talk about antibiotics that are commonly classified into bacterial and bacteriostatic, we want to discuss, are bactericidal agents more effective than bacteriostatic? And perhaps more importantly, is making this distinction clinically relevant? We can talk about kind of basic topics that are pneumonia and skin and soft tissue infections. So one of the most common topics and also the most clear outcomes is in pneumonia. I was able to find multiple trials directly comparing the efficacy of linezolid versus vancomycin in community-acquired pneumonia and nosocomial pneumonia. And linezolid was found to have similar efficacy to vancomycin in all of these trials. The outcome may be due to, in part, the relatively poor penetration of vancomycin in alveolar tissues, whereas linezolid penetrates these tissues very well. However, overall, their efficacy was found to be the same. There was also trials involving tigecycline, which is bacteriostatic, versus levofloxacin, bactericidal, in hospitalized patients with community-acquired pneumonia that found tigecycline to be non-inferior as well. The only recent trial that I could find in these cases that showed cidal to be superior than static was comparing imipenem to tigecycline, which showed a higher mortality in ventilator-associated pneumonia in patients treated with tigecycline, but no difference in patients with community-acquired pneumonia. And upon closer review by a meta-analysis paper of this trial, the tigecycline dose was likely suboptimal in the trial. Further, among the many trials involving skin and soft tissue infections, the results were straightforward as well. This example showed linezolid to be non-inferior to dalbavancin, including even for MRSA. So now we can move on to the special cases that are more complex. One is neutropenia, which involves an immunocompromised host, and another is infective endocarditis, which involves an immune-privileged site of the cardiac valves. So this trial compares linezolid versus vancomycin in a randomized controlled trial with 300 febrile neutropenic hospitalized adults with cancer, with proven gram-positive bacterial infection. This is one of the only studies on this subject to include neutropenic hosts, a group of patients for which bactericidal therapy has traditionally been thought to be superior. The trial concluded that linezolid and vancomycin had similar efficacy in febrile neutropenic patients with cancer, and thus a bacteriostatic agent was not inherently inferior to a bactericidal one. Now we come to infective endocarditis, which, as I mentioned, was one of the origins of the debate, and a main reason that bactericidal versus bacteriostatic distinction is still made. No trials exist that explicitly compare a bacteriostatic regimen to a bactericidal one in this situation, given that it is a difficult-to-treat, life-threatening illness. However, one study found that linezolid was well-tolerated and associated with the same outcome as in patients with gram-positive infective endocarditis treated with other antibiotic regimens. In the paper, they went as far as to measure the MIC and MBC for linezolid, proving that it technically did act as a formal bacteriostatic agent. The purpose of the trial was mainly to add linezolid as part of an antibiotic regimen for patients that could not tolerate initial bactericidal regimen due to antibiotic intolerance, allergies, nephrotoxicity, etc. However, it was important to note in the trial that ultimately 8 patients received linezolid as monotherapy due to the reasons above. When analyzing the subgroup of patients receiving linezolid as monotherapy, no difference in the in-hospital or 1-year mortality was found. The same results were observed for the group of patients receiving linezolid in combination with either rifampicin or gentamicin. However, the paper still concluded that linezolid should be used only in combination therapy, given the very small monotherapy group and the life-threatening nature of the disease. So, where do we stand on this debate? There are many meta-analysis papers that discuss this topic, and this one says that the bactericidal versus bacteriostatic is divided arbitrarily, when rather one might consider it as a continuum. In the formal definitions, why do we talk about a 24-hour period and why a 1,000-fold reduction? Further, bactericidal activity is not an invariable property of the antibiotic. It can depend upon the organism and the growth conditions. For example, strep pneumo is intrinsically quite a susceptible organism. It is readily killed by antibiotics that are bacteriostatic against hardier species. However, this paper concludes that rigorously designed randomized trials directly comparing bactericidal regimens to bacteriostatic ones don't really exist. So we just have to go off of the smaller trials and the results that we've seen there. Another meta-analysis, including 33 different trials, had very rigorous inclusion criteria, meaning they could only comment on pneumonia, skin and soft tissue infections, and abdominal infections, and they stated that in those cases, bacteriostatic versus bactericidal distinction is unlikely to be clinically relevant. There was a scatter plot found in this paper that combined all of the trials. It showed that treatment with linezolid appeared to be associated with a better clinical cure rate compared to its bactericidal comparator, which is kind of an interesting finding, this right here. There was no benefit detectable for clinical cure rates among subgroups of bactericidal antibiotics. I found this interesting that linezolid had such a statistically significant superior outcome. Another rigorous meta-analysis stated that in the treatment of less severe infections, there was not a difference in clinical outcomes or mortality between the two types of agents, and often in the cases that bacteriostatic agents were superior and or more cost-effective. I actually found that interesting because I looked into the cost of linezolid versus vancomycin, and vancomycin is less expensive. However, given that it requires monitoring and pharmacist dosing and it's IV only, it would be more expensive than using linezolid as a PO dose and sending the patient home. So, cidal versus static. The data at hand suggests that this classification is clinically irrelevant if used for if used for pneumonia and skin and soft tissue infections, given that bacteriostatic regimens can be equally as effective as bactericidal ones. Rigorous trials do not exist for the special cases of neutropenia and infective endocarditis, but limited evidence postulates that some agents such as linezolid may be non-inferior. So characteristics that may be more important drivers of the clinical efficacy are optimal dosing, pharmacokinetics, tissue penetrance. When bacteriostatic agents were found to be inferior, the explanation appears to be more inadequate dosing and/or achievable levels at the site of infection, not necessarily the rapidity of kill. And these are my references.
I'm sure there will be comments.
For the linezolid in infective endocarditis, was that from the start, or did they get IV initially and then linezolid? Or a bactericidal and then linezolid later?
In that trial, they all started with the bactericidal therapy that we start all patients on. The trial was really trying to figure out what could be used to replace those antibiotics in patients that don't tolerate the initial antibiotic therapy. It was just interesting finding that some of the patients ended up on monotherapy with linezolid.
The place where I have problems with static versus cytal is bacterial endocarditis, and particularly enterococcal endocarditis, because that's the one I think is hardest to kill the organisms dead, as opposed to just inhibiting their growth. So again, the legacy of my training was you always had to use cytal drugs to treat enterococcal endocarditis. It was also thought to be important in meningitis, and that primarily comes from the studies using penicillin versus tetracycline, which I think you just didn't get high enough levels of the tetracycline. So most studies with antibiotics are non-inferior studies, which means you just compare them, and that's why they get FDA approved. But I love linezolid, and it is a static drug, so.
Well, one of the things that I never really understood, I think, before she did this, and I looked at the slides, was that, my concept of bacteriostatic was just that it doesn't kill. It just sort of stuns the bacteria, keeps them from dividing, and then you're dependent on the immune system for actually curing the patient, which is why, the whole hypothesis with endocarditis and neutropenic patients, why it's not thought it's good to use in those people. But clearly, these antibiotics are killing bacteria. They're just not as they don't kill to the same MIC, or MBC is not the same, but they're still killing. Those studies are all done in vitro. There are no phagocytes, right? So you're doing more than just keeping them from dividing. You are killing them. You're just not killing them as effectively. And part of the issue seems like a concentration issue, or a dosing issue, that if you dose them high enough, they're probably just as effective. At least that was shown in some of these studies. So in that last meta-analysis, I think there were 60 studies that they looked at, head-to-head comparisons, and out of the 60, only one out of the 60 showed the bactericidal comparator was better than the static drug. And in 6 or 7, it showed that actually the bacteriostatic was superior. So, I don't know. To me, it was all, this is the dogma, this is why we're here. I think there's not great evidence for a couple of the conditions, but at least in the conditions where they've actually looked at it, the bacteriostatic, to me, seemed to be just as effective or better.
Again, it used to be when we were treating bacterial endocarditis, we used to do bactericidal levels and do serial dilutions of blood to see if you had enough killing, and then that turned out to be incorrect and showed no efficacy, could not predict efficacy at all. And so I think you're right about that, but the whole reason we're doing this is to sort of change the paradigms.
That's the idea anyway. Question is,
makes it paradoxical.
The question is, are we changing the paradigm, or should we? Is it a myth bactericidal antibiotics are more effective than bacteriostatic antibiotics? Based on the data that's presented, what do you guys think? So we're going to vote. We're done with comments. How many people think this is still true? That we should. How many think it's plausible? Few. How many think it's busted? I think the majority think it's busted, even in the 2 infectious disease specialists. I'm shocked. No, unfortunately. All right. Well, go ahead. You get to
Bust it?
Yep.